So Jerome is a 31-year-old man. He's had a cough for about a month, and it just won't go away. He also describes over the last week, he's had this headache that's really been giving him a lot of trouble, very, very uncomfortable. Sort of see this picture of him just sort of trying to apply pressure to the head. He's just uncomfortable. So pretty detailed HPI. I wanted you to have a glimpse at his story. So this is sort of what happened with him. He's coming into a primary care clinic with purulent rhinorrhea almost exclusively from the left nostril. He's got pus in the nasal cavity, and he's had now this constant headache, which he describes as moderate, and it's begun a little bit over a week ago. Now, he has a history of migraine, so he knows about headaches, but this does not feel like his prior headaches. This is sort of local in its presentation in the left temporal region, but he feels like something's just squeezing in, like it's just applying this constant pressure, and he's very, very uncomfortable. Hard to work, hard to sleep. When his symptoms first began about a month ago, he was in a good state of health before this occurred. When the symptoms first began, he just felt like he had a cold, a pretty bad cold. It gave him runny nose and sneezing and cough and congestion and some just generalized fatigue. But he's had that before. You know, it's not uncommon, and he thought he was sort of on the path. So over the course of a month, from a month ago to where he is now, he saw those cold symptoms begin to sort of change. The sneezing stopped, but the congestion began to build, and he had more and more pressure in the face. And so that's kind of where he is. What key bits of information are you still really wanting to know next? What are you just really compelled to ask or try to figure out? Think about that just a minute. And the folks that are watching with us too can sort of create their mental list of what key bits of history that we really need. And then, so think about just a minute. I like where you go. No, that's okay. Think about just a minute. I think it's very appropriate that in Colorado we talk about allergies. The door opened on the plane and whoosh, it hit me. Beautiful skies, beautiful mountains, and nasal congestion. Go on the website. Maybe not. So history of allergic rhinitis or other allergy symptoms. What else?
Dental pain.
Is he having any pain that might suggest some type of other source? Dental. Okay, I like it. What else?
Fever.
Has he had fever?
What's he trying to resolve?
Is he using, are there any relievers? We've talked about aggravators, but are there other relievers? Are there things that are giving him symptomatic relief that may clue us into what's going on? I like it. So let's see what he says. So he presented to the emergency department actually 2 weeks ago, and he was diagnosed with an acute sinusitis and treated with an azithromycin pack. He now reports thick yellow-green discharge that's constantly draining, and it's not being relieved by decongestants. When he was treated through the urgent care tract of this emergency room, it was recommended that he pick up some over-the-counter pseudoephedrine, and he used that, and he actually reported some good relief of congestion during those first sort of couple weeks from the pseudoephedrine. He's using it at the same prescribed dose, or the recommended package recommended dose, but he's not getting that relief that he had before. He had fever about 4 days ago. And at this point, he describes a really aggravating dry cough, kind of a hacky cough that's making it difficult for him to sleep at night. So you're asking the questions, or at least I'm anticipating, right? So his past medical history, migraine, he has 2 per month on average if you look at his course over the last year or so. He has a family history of sort of cardiovascular and metabolic disease. His mother's diabetic. His father suffers from hypertension and cholesterol problems. From a social history point of view, he doesn't use any tobacco or illicit drugs. He has 2 toddlers in his home. I mean, both kids are less than 6 years old. So that's a relevant bit of social history. And he drinks about 4 glasses of wine per week, self-report. So sometimes for men and for women, we can sort of ratchet up that alcohol intake estimate. But he seems to be a pretty reliable and good historian. So from a medication point of view, 500 milligrams of acetaminophen over the counter, so that's extra strength. He's using 2 of those every 4 to 6 hours for headache. He began like maybe 2 or 3 days ago when this cough began to bother him. He's sort of in was intuiting that his cough was related to maybe postnasal drip, or which I think is pretty good thinking. And so his wife recommended that he use a medication at nighttime to kind of help with that. So they were using the Tylenol PM to sort of help dry up and then also help treat some pain as well from that nighttime cough. I mean, it maybe hasn't been going on long enough. He didn't really say whether or not that had been particularly helpful or not. Or at least the record didn't show that. Pseudoephedrine, as I mentioned, he's using 60 milligrams 4 times daily as needed, and he has not used any of his Maxalt, which he has during the course of time that he's had these symptoms. He had a rash as a child with amoxicillin, but doesn't really know anything more than that. That's basically his history. Where do we think we're headed? I mean, what's on your short list of concerns here? What kind of sinusitis? Acute bacterial sinusitis? It's probably not long enough to be recurrent, right? Allergic sinusitis, vasomotor sinusitis, I mean, any other causes? Fungal? His little 2 children, petri dishes, are sharing germs? I think that's probably highly probable. The good thing about common things is they happen commonly, right? So that happens all the time in all of our patient populations. Okay, so leaning toward sinusitis. Are you still sort of thinking maybe there's an abscess there or somewhere seeding it, or are you feeling better about it? You don't have to rule it out. I'm just asking because you brought that point up. Maybe, maybe not? Okay. So Caucasian man in no apparent distress. Oh, he looks a little tired. You can look at his vitals here. He does have a increased temperature. Can see here on the ears, nose, and throat exam a couple things. Certainly erythema around the conjunctiva. He's got some nasal crusting and mucosal hypertrophy. It's really dramatically worse on the left than it is the right. I don't see any polyps, or no polyps are noted. He does have very thick, purulent drainage, postnasal drainage. There are no lesions in the oropharynx that we can see. There are, the ears appear normal, at least on exam. There are no perioral concerns. And aside from the sort of glossy postnasal drip and erythema, there's no exudate that's discernible in the oropharynx. His neck is supple, it's got good motion, no palpable lymphadenopathy, no tenderness there. Lung exam, fairly clear. Cardiovascular exam seems benign. The rest of the exam seems pretty benign. From a diagnostic point of view, to try to consolidate this diagnosis or refine what we're dealing with, what would you do next? Or do you have everything that you need to be done to make that next move into a sort of a clinical disposition and a treatment plan? Well, he got treated with azithromycin, and he's here with symptoms and fever. So you want to image the sinuses? What are you looking for? What are you trying to find or hopefully not see on a sinus film or a CT scan or something? Does anybody else want to do a radiographic image of the sinuses? It's primarily all out of the left. You could look for a source with imaging. And now people are controversial about x-rays or whether we do CT scan. There's a lot of people differ quite significantly. There's a lot of criticism of plain radiographs, although they'd be the cheapest route. There's some practice guidelines from the otolaryngology world that might suggest it. Although some people will use a radiograph as a screening tool to look for something particular, not the same thing they're looking for when they're trying to do a comprehensive examination or assessment that maybe an otolaryngologist might be doing. So I think there's some wiggle room there. But if you believe there might be some source that needs a surgical intervention or needs some other treatment approach, then I think it's reasonable to image it. I think you could also probably consider just treating it and see if it resolves.
We haven't done some basic things, like has he irrigated his sinuses to see if he can get any relief? Once you've got those blockages, it's difficult to get it to drain, and something that would cause it to thin.
So you're thinking also about sort of these non-drug really approaches, right? So let's take ourselves 2 weeks back and put us in the urgent care track of the emergency room, and what would we have done differently at that point? I mean, that would be a good time to say you need to use a neti pot or saline irrigation and you need to get after it, right? What else? Hydrate or humidify? Is that where you were?
I was going to say if we've got bacterial, different antibiotic.
Okay, so either choose maybe a more appropriate antibacterial drug. That would be good. I like that. Follow the guidelines. So you were a real pro macrolide the last round. Now we're tossing those under the bus. I like it. So I think the choice could have been better if we would have met it. And maybe humidify or vaporize or something to help loosen. Something to thin secretions.
To go further back, to look at a history, this might be recurring, and what if he's got a deviated septum that's causing the problem?
So if you believe there's some structural issues, particularly if he's got a history of multiple recurrent infections or frequent infections, then maybe that would lead us towards more imaging, right? Or either refer us to an otolaryngologist or a surgeon even to really think about that. I think that's good. I mean, and I haven't given you that because I didn't have all that from the records from the case, but I think all those are really good points of clinical reasoning. Because otherwise you're just going to participate with the antibiotic chain.
And if it's been treated at home, if they were treated, what were they treated with, and did they have satisfaction?
So you can do a little detective work as well if you don't want to source the agent or you don't have a way to culture to figure out what it is and get a clean source. You can find out, if he's been holding a sick 4-year-old in his lap for the week before he got sick, what was the treatment that successfully eradicated the infection in the child, and that might give you some clues about where you had. I think these are really quite good thoughts. Oh yeah, what was your comment here?
Sometimes patients, continue to just suck down large amounts of caffeine and they dehydrate at the same time, and they just feel so lousy even though you've been treating adequately.
So maybe a little bit of a lifestyle consideration.
Right.
I think that's really quite good. Particularly, I mean, we have drugs that are expectorants in mucus thinning, but really the very best expectorant on the planet is water. Plenty of it. Yes, ma'am.
In the exam, I remember for sinusitis, clear things to me was just palpating.
To see if there's tenderness, yeah. I mean, he's absolutely got focal, sinus tenderness.
And then decrease in dairy increases.
So thinking also in particular, particularly if there's a viral infection, being cautious about the amount of dairy intake can help because dairy has certain reactions that can make it a little harder to clear these infections. I think good point of sort of counseling. So let's look at where we're going to go. So are there drug-related therapy problems? I mean, anything on his medication list that sort of jumped out to you as a real red flag? So let's talk about the acetaminophen, which seems to be a generalized point of concern. How much is a safe daily dose for a typical healthy adult without any liver problems? People have learned in school 4, but really probably 3,000 milligrams a day is a better estimate. 3,000 milligrams a day of acetaminophen, if you have a healthy liver, for an adult is okay. If he's using 1,000 milligrams with 2 extra strength products 4 to 6 times a day, and he's also using another 1,000 milligrams with the sleep aid, then he's well over his issue. So we need to pull that back. And if he needs something else to control in the interim, maybe we need to prescribe or give him another recommendation that he can alternate with that acetaminophen, like a nonsteroidal drug or something else, to maybe to get symptom control. What else are drug therapy problems with him?
They were using the antihistamine and Tylenol to help give some relief, and it's like Benadryl's not that great.
So the diphenhydramine that's a part of the sleep aid product may be creating or contributing to surprise. So it's kind of it's not an easy, it's a two-edged sword, I guess is maybe a way to think about it. There are some people who, if you use medications to control their allergies, will have much frequent rates of sinusitis. And then there are those that are trying to use the antihistamines for symptom relief, that it does nothing more than really dry and sort of crust the secretions, and then it's harder to eliminate, and it may actually contribute to prolonged symptoms. So I think in him you could make a case that using the drying agent probably isn't helpful, because what are we trying to do? We're trying to get this thing to sort of drain out. So I think that's really, those are good points. So there may be some diminishing return on the use of his pseudoephedrine over time. Okay, fair enough. He maybe drinking a little wine. Is that a bad thing? So maybe he needs more water. Maybe his juice of choice needs to be water. Sounds pretty good. So if we think this is a bacterial sinusitis, what pathogens do you think are there? I'm going to do it to you again. Haemophilus influenza, strep. What else? We think it's staph? He doesn't work in emergency. He went to. No, he's not a healthcare worker. He works in business. I don't know. I mean, I'm just throwing it out there. So I'm going to put staph with a question mark beside it. I missed that.
Likely positive organisms, the book says, recurrent.
Well, we're not talking about the book. We're having a discussion, right? Moraxetta coloratus, MCAT. What else? Anything else? That feel pretty good? So it's the same kind of discussion here. It's think about it. You're going to primarily have skin flora or other respiratory pathogens, which are going to be very similar to those that cause otitis media or pharyngitis. So strep has got to be on the list. Haemophilus influenza has got to be on the list, and particularly with the kids around, that's a high probability. Moraxetta coloralis could absolutely be on the list. How about staph? Staph could be a cause, but there are components of his history that we need to reconcile whether or not it's high or low on the list. As well as Pseudomonas. So does he have a hot tub, or has he had recurrent, or has he had hospitalizations? If it's staph, is this one of multiple recurrences? So if there's a recurrent pattern then it would be high on my list. If he has had exposure or is caring for somebody who's a community-acquired MRSA colonized patient, does he have an elderly parent that he cares for the home? Or so you have to bring the history together. But the common respiratory pathogens will be the common causes of acute sinusitis, and that's what empiric guidelines are built on. But asking the questions that you did about are there other associations is absolutely the right thing to do. But that comes when you gather history, and as you gather that history and begin to make your diagnosis, it's that information that's in your mind that's going to help you build out a list of 3 or 4 or 6 possible pathogens, and that's going to guide where you go next. So let's look at just from a symptom point of view. I agree with everything you said about the drug concerns. Allergic to penicillin is really undefined, so we're probably going to maybe err on the side of caution, although we could talk about that a little later. All he has is a childhood history of rash with no other history. So in terms of the acute sinusitis diagnostic criteria, he's going to have he's going to be pretty in line with those, right? Symptoms for more than 7 to 10 days? Check. Purulent rhinorrhea? Check. Local sinus pressure? Check. Pus in the nasal cavity, so he's 4 out of 4. You can also diagnose it by doing a gram stain of the nasal mucosa or by taking a sample and identifying that there's a predominance of neutrophils. So either way that you go, I think it's not hard to, there's not much arguing with his diagnosis. This may be a little hard to see. It's probably better represented in your slide, in your book. This is on page 23. But one of the things I just wanted to share, although we've kind of done this, is that this sort of walks you through the diagnostic and the approach to management for this type of patient. And it also tells you when they believe, or when the specialists recommend putting in place imaging or referral to a specialist, which is the bottom sort of central box. So in terms of risk factors for antibacterial resistance, having age less than 2 or greater than 65 or being in daycare would be risk factors. Prior antibiotics within the past month is another risk factor, so he has a check by that one. Prior hospitalization in the past, don't really know that, but it hasn't been in the last 5 days, so we can rule that out. Other comorbidities, he doesn't really have much in terms of substantial comorbidities. He's got migraine, but that doesn't seem to exactly correlate. And there's really no evidence that we have from history or exam that he's immunocompromised. So other than the prior antibiotic use here recently, that's about it. And this sort of walks you through the guideline. I don't want to read to you an algorithm, but I wanted you to go through the experience of being able to sort of think it through in this way. And as we think about antibacterial drugs, Streptococcus causes about 30 to 40% of presentations like his, H-flu causes about 20 to 30% of presentations like his, and MCAT causes anywhere from 4 to 20. It's a lot of regional variants of these. And there are also viral causes, as we mentioned, and then there are some little different organisms that are more common in chronic and recurrent patterns. But that gives you sort of the classic and the most common, and then from that list and his story, you would be able to make your plan. Where do you think you're going to go with antimicrobial therapy? Because that whole prior treatment thing kind of throws something in the, kind of confuses the issue a bit. What do you want? Where do you want to go with? I mean, I think we should do all the things you mentioned. You know, moisture, hydration, irrigation, aggressive irrigation. What do you want to do in terms of treatment? Antimicrobial selection. So an augmentin, so a penicillin with a clavulanic acid. So the guidelines would agree with you that that would be an appropriate first choice. On the other side is he's got this rash, history of rash as a child. I'm not saying you're not right, because you may very well be. Do you sort of try to get some more information, or just sort of kind of glaze over that with some guidance, or do you say, I don't want to take a chance, I'm going to move in another direction? Doxycycline, I think that'd be a reasonable choice. How long would you do it? 10 days? Okay. What else? What other options? Try to write down these things so I have good notes. Well, so I think regionally some people may use sulfa drugs. There's some gaps in its coverage across the board, and so unless you're really, unless you know this is a patient that maybe has had a community-acquired, you know, sort of MRSA infection, or maybe somebody that's had recurrent and sulfa has been shown, has demonstrated effectiveness for that type, it wouldn't be one I would just pull out of the bag for this individual patient. So the beta-lactam would be the target choice. There's a little bit of resistance with some of the cephalosporins for some of the more common causes on this list. So I think regionally you may or may not have a great success rate with the cephalosporin. Using the beta-lactam in the augmentin form, or the amoxicillin clavulanic would probably be preferred. But there are also pockets of the country where probably you'd be okay using the cephalosporin. It all depends on how much cephalosporin use has been used for pharyngitis and otitis media in the children in your community. And some of it just beat down those drugs by using those so rampantly, particularly when there's a lot of daycares or schools in the area. But doxy would be an alternative to a beta-lactam, so I like where you're headed there. So Omnicef or Ceftonir would be one of those cephalosporins, exactly like the one I was just sharing with you, that's been so rapidly, so rampantly used in the pediatric population that it would be hard for me to tell you what to do locally, but I can tell you nationally, you'd have to make a case for it. Mm-hmm. That's again.
Should be with clindamycin.
So the issue is. Because of gaps in second-generation cephalosporins coverage over the common ones, if you're going to use it, this is the same theme. Sometimes you have to add something with a little bit more gram-positive coverage. So adding Clinda to it, or even adding you know, doxycycline, sometimes they'll even use in combo, is they're having to move to combination therapy because of small holes in the spectrum of the cephalosporins. How about a fluoroquinolone? I think of would a fluoroquinolone give us the coverage we want? Would it give us the H-flu, strep, and MCAT? Fluoroquinolone would be a reasonable choice. So he's at risk for resistance because he's had a macrolide failure, unless we were treating a viral infection with the macrolide and then he overgrew bacteria. Now he's got a bacterial infection. So it's a little bit of clinical reasoning here. I think you can make a case for. I'm conservative, so I might not go the amoxicillin route because of the rash history. But I think you could make a case if local data said it was okay to do a cephalosporin with or without Clinda. I think you could make a case for doxycycline, and I think you could make a case for a fluoroquinolone that had respiratory coverage, such as moxifloxacin or levofloxacin. the three products that are currently on the market by trade, so you just have some, I'm not trying to sell products, but I want you to recognize the drugs, would be Factive, Avalox, or Levaquin. Those would be the three in-class respiratory fluoroquinolones by trade name that lead you towards those products. I think there's a case to also be made, too, that we try to reserve the fluoroquinolones for the most severe cases so that we have them when other treatments fail. But because he's got a penicillin allergy, you may have to detour from that practice in him in this case simply because your options are more limited. But that's where we are. If you went with doxycycline, if you went with the fluoroquinolone, or you went with the cephalosporin, maybe with another agent added, I think those would be reasonable. If you have a penicillin allergy, is it very common to also see a cephalosporin allergy because there is cross-reactivity, or is it uncommon? I mean, it may be as infused in 1 of every 1,000 patients. Although we certainly keep it in mind, and we probably modulate when we prescribe cephalosporin for people with a history of pen allergy towards those that had milder reactions with penicillin. I mean, I don't know that I would jump that fence if somebody had a history of highs and respiratory issues or angioedema, but if somebody had a very mild skin reaction, it's still a reasonable choice to move to cephalosporin without being overtly concerned. I'll come back to you.
I'm sorry. With the doxy, we have, it's every 4 hours, the doxy. Is it BID?
BID. Do I have a mistake?
No.
Okay.
I was just thinking about, sorry.
No, that's right. Twice daily dosing on that one. And another comment here?
I think in this area we're up to or a little over 30% resistance to Zithro. So
It's all over the country. So macrolide resistance with these upper respiratory infections, it leaves you big holes in the pocket of what you're covering. And so while they had great value for a period of time with strep and H flu, we can't reliably use those as empiric therapy like we used to. And that's just part of the times. And we'll be having the same conversation about some other class of drug in a few more years. It's just the way it is.
and we're using 500 for 5 days now.
So they still have value with atypical infections, which we talked about, but their former uses are no longer their new uses.